So the Pinky Show and Dr. Huey have helped us take a little bit closer look at managed care, specifically managed care organizations. And if you actually Google managed care, one of the results that you'll get back is information around managed care on the stock market. So you'll actually see financial reports around the dividends that managed care is returning to its investors. This whole idea that managed care, because it's privately driven, that it is actively exchanged on the stock exchange, so you'll find even reports around that as well. So managed care in mental health is typically what we would refer to as specialty mental health. That's actually our managed care system. And in each and every county, there's a mental health plan that is essentially operating as a insurance company. So each county operates like an insurance company, much similar to what you'd see as the managed care organization from the Pinky Show. Now, the basic principles behind managed care when it comes to the mental health system is primarily cost containment. So specific reimbursements related to specific modes of service, and you would better know that as coding. So when you are coding your time at work or at your internship, ultimately what you're doing is you're conducting a billable activity that's being charged against a funding source that pays for that type of activity. We do a lot of data measurement in specialty mental health, and we do that on a couple levels. First, we talk a lot about productivity, because what productivity really means is the more billable work that you do, the more that your work generates revenue for the specialty mental health clinic. And so productivity is measured on a regular basis. So, for example, a clinic might have something such as a productivity dashboard, which is a tool that actually shows employee productivity relative to billable activities versus non-billable activities. And then we might look at data sets more in totality to actually be able to look at our progress towards outcomes. So the old school way of doing that is we talk about Medi-Cal penetration rates, for example. In other words, out of the folks who are eligible in a specific population, let's say that's 40%, and we're serving 12%. Why is there such a significant difference between what we're actually serving, i.e. the penetration rate, versus that number in to the total number of folks that are eligible? Why is there that difference, and what could we be doing differently to ensure better access for folks who are eligible? So that would be kind of the old school type of measurement. We measure, for example, a lot about inpatient stays, number of bed days that an individual may stay versus the average, to be able to identify frequent users or high consumers as far as who consume a significant amount of the resources. Remember the old 80-20 rule, which is 20% of the people that you serve suck up 80% of your available resources. Managed care also provides an element of organizational control, typically today, that is implemented electronically, through things such as practice management, electronic health record, those types of things, in that quite often the work that you are allowed to do is given via permissions through an electronic system, such as if you were only allowed to code to certain billable activities because you aren't licensed for other billable activities, then perhaps only those codes for which you are eligible to provide service under would actually show up in the electronic system. So that's a great example of managed care being implemented electronically. one of the main arguments that Scheid has that we're really not going to get too much into this lecture, but nonetheless it's important for us to recognize and for you as professionals in the field to recognize as well, which is that the managed care model has a significant consequence on social worker professionals, and typically it causes burnout and job-related stress, because there isn't a lot of flexibility in what we're able to do, and we have to unfortunately fit the situation before us into compartmentalized billable activities, and that may not always quite meet the needs that are before us at that particular time, and that poses a significant challenge and effort on our part, which does lead to stress and burnout. Especially as it's related to staying on top of progress notes and entering information in the chart timely and completing the entering of codes related to the billable activities that you conducted that day, or worst case the day before, and the constant pressure to get that information turned in timely. And then also having to deal with the fact that when that information is audited, that you perhaps did something wrong that turns out to be a disallowed cost and actually ends up costing the organization a significant amount of money. Now, when you think about the model that we developed in this course, where you had the mental health system in the box to the left and the administrative unit in the circle in the center, and then the levels of oversight to the right, such as Congress, the legislature, the Board of Supervisors, voters, and consumers. So when you think about that box marked the mental health system, and then the components that we looked at that make up that one box, and we looked at public and private hospitals and corrections in each of those boxes that make up the basic components of a mental health system. And part of one of the things that Scheid argues for managed care is that managed care, because it's both similar in the private and the public sector, that those first two boxes that we had on the left of the diagram that we originally created when we were beginning this class, that public and private system become less different because they're being overseen by a very similar structure, or in this case, managed care. And then, of course, we're challenged both professionally and ethically over the fact that managed care doesn't always provide the level of flexibility that we need in order to meet the demands or needs of the folks that we are serving. And in fact, quite often, the structure that is imposed by managed care over the work that we do becomes inflexible and limits the number of choices that we have as professionals in what needs to be provided to our client. And so we fall into this thing that Scheid argues about caring versus control, and that there's such significant control over treatment decisions that the autonomy of the provider is lessened, and that leads to difficulty in the provision of care under a managed care model. Now, ultimately, what managed care is really all about is controlling costs by limiting access and limiting costs. And so it's really common in a managed care format that we actually want to steer individuals to services that cost less and actually avoid high-cost episodes. And, the prime example of that is obviously, to the extent that we can, we want to avoid psychiatric hospitalization. And there's a number of strategies of doing that, from something as simple as a safety plan and a release of a 5150 hold to something a little bit more complicated, such as a 23-hour hold, where we don't quite commit the individual to psychiatric care, but we still hold them nonetheless to give them an opportunity for their situation to improve. You'll hear a lot about, in your scope of practice, definitions of what makes up medical necessity, in that there needs to be the opportunity that an individual actually will improve from the treatment that they are being provided. And if that there is no chance for improvement, then it perhaps is not medically necessary. And so we limit, especially in pre-approval type of activities, that care that will only have an impact on medical necessity as care that should be provided. If there isn't a medical necessity, then the care is denied. There's also this whole argument around parity, and this is actually a really interesting policy to take a closer look at and actually analyze. And so from time to time, I do have students that pick parity as a subject for or as a topic for their policy analysis paper. But typically what we talk about when we mean parity, what we're meaning is that everybody gets similar services, and more recent legislation has been related to parity for drug and alcohol services and mental health services on par with primary care, because obviously most plans and programs in the insurance industry focus on primary care first and foremost, and mental health, behavioral health, drug and alcohol services are usually secondary to that. But even within private care, the system itself, managed care, is specifically aimed at providing services in short and fewer episodes, and it really isn't set up for the chronically mentally ill. And so when we actually really begin to look at healthcare reform, when we look at the implementation of healthcare reform, we're going to begin to see a division of care, a division of labor through the providers of care. And so, for example, it's highly unlikely that the private sector will ever do much around the chronically mentally ill. And so then that would be a population that would be more likely to be supported primarily by public community mental health. And then the other piece of parity is this idea that Scheid argues about standards of care versus keeping costs low, that there's a real significant balance that needs to occur there that's difficult to maintain in a managed care setting. So overall, really, managed care is about access, controlling access to care and limiting access to care. And for those who do gain access to care, they are steered towards less costly forms of treatment. That there is a level of quality that is maintained, but historically, analysis and research shows that managed care has really fallen short on the quality front. But then the catch-all, the most important pillar out of managed care, that which truly is the most significant impact provided by managed care, is the containment of costs and controlling costs. So really we can summarize it as managed care really limits costs and it limits access, but it provides low quality. So with the Affordable Care Act that will be implementing fully in 2004, more commonly known as Obamacare, one of the things that the ACA contemplates is some form of managed care. And one of the models that has been discussed and is emerging as a probable form of managed care under the Affordable Care Act is what's called an ACO, or an Accountable Care Organization. So an accountable care organization is a form of managed care. It is a network in which things like hospitals and providers and programs will come together and form a unified level of service organized under this particular ACO. And then the ACO would provide functions relative to compliance and quality review and utilization review, very similar to what you see in a department. And the primary change or difference between the ACO approach versus the more old school traditional form of managed care is the focus on quality. That quality really does set that apart. So ACOs are an emerging model in California and in the country as it relates to the implementation of healthcare reform in 2014. So this is a very important concept for you as MSW students to understand, because the world that you are emerging into, what's changing in the world for which your career has been aimed, the industry that you've chosen to pursue a job in, or to advance your career in is dramatically changing before our eyes, whether it's realignment from the state of California or the implementation of healthcare reform. There is significant change in every direction on the horizon, and your ability to not only recognize that, but to understand it so that that adds some level of comfort and confidence to what you're doing, but then also truly being prepared to manage well in that environment by knowing what the opportunities are that are available to you. So accountable care organizations, the ACO, is an emerging model that you really need to at least have a basic understanding of, because it'll be really key to your future. So that'll be the end of this particular segment, and then we're going to look at a video which is next that talks about accountable care organizations, and then you'll come back to the PowerPoint presentation.